a year ago, we were all struggling and trying to figure it out. What is this? SARS-CoV, I mean, we didn't know SARS-CoV, I think, came out. The end of like January 30th, WHO said this is an emergency. Then 31st, at that time, HHS Secretary Azar declared public health emergency United States. And then after that, you can see the sea change. So many things happen in terms of, the COVID-19. It was a formal nomenclature of the disease, SARS-CoV-2. It's a mouthful at that time. People didn't want to say SARS because it will make everybody worry about SARS and MERS. So hush, hush kind of thing. And then COVID-19, everybody just honed onto the COVID-19 disease. And what a roller coaster ride we all have been through. March 16th, we have our first case in Onondaga County. I was talking to a reporter a few days ago, and she said, "What do you remember of that day?" I said, "I remember we were in a 16 on the 14th floor. This is the conference room in the Civic Center. And there was lots of reporters. We were all sitting close to each other. I was standing in the podium with the county executive. We were all maskless, right? Crowded there. And look at that, how much has changed at this point. We got very much involved in case investigation, contact tracing. You all know that I'm not here to go over those things. You all have been excellent partners. The shutdown, flattening the curve. The summer created some of the problems for us because people just forgotten that COVID still exists. And looking at some of the other states, people kind of didn't behave well either here. And we had the second high spike quite a bit, which continued through the winter time. The school did open in fall with the restrictions, and continue to operate with the online, remote. Some of them actually brought their the students full time also, so that a lot has happened. And the physician practices went into remote mode. Telemedicine has started to open up. We in the health department with the other county agencies, a lot of shutdown impacted us as a essential workforce. We continue to work because that's what we were doing. There was a little glimmer of hope started to come with the vaccine. When we saw the first trial, some of it become so politicized that it just was uncomfortable at that time. But the scientists continue, and then lo and behold, in December, we got the approval, and then December 28th, we did our first clinic in the War Memorial, actually, we did that first one. We were one of the first clinics, I think, in the state for a mass vaccination clinic, because I have to say my county executive, Ryan McMahon, is the champion of the public health. He is a great partner. He just, listens to, absorbs everything, and literally goes out and gets things from the resources, from whether I need staffing, whether we need anything else, to the vaccine. And that's why we are able to get a lot of vaccine. So it just makes a big difference that we started to get Moderna first, and then accidentally we ended up getting Pfizer, which I just feel like, oh my God, why did you give us a Pfizer? We didn't even have the ultra freezer at that time, which we have put in order, but we have not received. But we were able to put into they send ice and a lot of those things. Believe me, I even transferred those dry ice with all those shenanigans. We did all sorts of things which we needed to do at that time to make sure our vaccine goes into people's arms. Since then, we have continued to do quite a bit of vaccination throughout in the community. We shifted from War Memorial to the On Center. It was larger, and then they had to play ice hockey there. And we also started doing some pop-up clinics. So our strategy have been for the vaccine is we follow the New York State Department of Health guideline. You are all familiar with the eligibility criteria that's posted on, if you go to the phase distribution, you can see that they're all listed. First it was healthcare providers, then it became other essential workers. And it was very difficult in the beginning because it was very hospital focused. the way the distribution occurred in the state was opposite of what we knew that's supposed to be handled in the pandemic. Local health departments are very much equipped to handle these sort of emergencies. I mean, I don't want to say that we were all prepared that well, but we have done a lot of drills, how things will happen if the vaccine comes, then how that will be mass distribution. Local health departments will be the key player in there. Then we will distribute that vaccine based, because we know our own community, whether it's a health system, whether it's outpatient providers, all these things we have continued to advocate with the state, but unfortunately, it did not work out that way. And then we were very shocked to hear that hospital systems became not to their choice. I mean, they got caught into that also. That was not their choice. They were not even asked to become the hub. And we certainly work with the hub, with the regional capacity. Onondaga is one of them. And pretty much guided through some of those things which we knew how it should be, and continue to advocate that this is the role local health departments do play, because everything is all local. We continue to receive first a little bit of a smaller doses of vaccine, and then we started to, at least in our county, we started to get larger shipments. It started, I think, with the, if I remember, I have to go to my sheet actually to look into, is at one point maximum doses we got was 3,600 doses for 1 week. Then it trickled down to 1,900, then 900, because we didn't know what was happening, because the vaccine was drying, the supply was drying up at the federal level. So it just created a lot of problems. So January was sort of a roller coaster. Then February was same. We didn't know, and we still don't know what vaccine we are going to get. The one fact is that between Moderna and Pfizer. So in the beginning, we all got Moderna because Pfizer was given to hospitals because they had the ultra freezers. Most of the health department didn't have. We did get our own, so we had the capacity. And we said we will take Pfizer too, but most of it, Moderna was our favorite. Johnson & Johnson was not on the horizon at that time. They were waiting and all those things. So we have continued to vaccinate through our efforts working with our partners. So I'm just going to talk about a little bit how our process works in terms of when you come to, how do you register? So looking at that, how people are going to come into mass vaccination clinic was a little challenge, because, how do you register? Do you purchase a new registration system? But anything which you really need to learn of that system. I think that's very important to remember. And then also we were all scrapped we are cash, it doesn't exist. So local governments are pretty much were in red, and we have to live within our means. So we had a system for emergencies, what we call ACUITY. This is a registration system for different small, that can do mass things, but was not designed for this. So we sort of started to using it, in which you put the online registration, we put all the things which we need, and then put it out to the community. That worked. Within few minutes it will disappear, and then people will have vaccination, line up for the vaccination. And we did not, as of it today, we never waste a single dose. We find extra people if we have 1 or 2 or 5 doses left. And we also started to realize that having online registration is not everything, because there are equity issues. Not everybody actually can do the online registration. People don't have access. Literacy is not, it's a big issue. So we have to think out of the box. Some of those things which we actually do practice in public health emergency, that how to do outreach to the people with disability, how to do outreach to the people who don't speak English. We have those connectivity. And also as a county government, our other departments, social services and Department of Children and Family Services and other ones, they actually deal with so many other community-based organizations that we really started to use them for our benefit at this point. Is that how do we use their relationship to have them as a trusted partner in the community and have them talk to their membership or to their clients and have them enroll. That was, and also we as a health department have worked with the health from the health equity lens. We have a health equity ourselves actually for last several years, a group which works with our, looking from the data point of view, looking from maternal child health, led program and different things. So we have those discussions, we have those relationships. And in the meantime, Hub, which is upstate, is the one who was responsible for the Hub. They had a health equity task force, which I think state has asked them to do that. So they were also looking into those to have pretty much put it in motion. So we use our existing relationships with the faith-based communities, which we do have it, and it got much more stronger during this time, because if they are not coming to the ON Center, if they don't have access to that registration process, we are going to go to them, right? That's what, so we work with the refugee community. We have like a Catholic Charities, Interfaith Works. We have some other organizations. These are a couple of names, so I'm just, throwing it out here. But there are multiple organizations who work with the different community throughout the county. A lot of focus end up having into that high poverty area with the zip codes. So we drive our efforts with the data, which is pretty much based on data. If you have, I think we are not there yet to put some more formal data on the website that I can just give you at this point based on what our vaccination has been. Our first doses so far in the county, not only in our community, on our only county website, county clinics, but also at the state site, which has been vaccinating a lot. Our partners in the pharmacies, whether it's a Wegmans, whether it's a Kinney Drugs or CVS, all of them, as of it, I think a couple of days ago, what the latest data were like, first doses over 100,000 people have received first dose. Second doses have been over 50,000, which is great. I mean, that feels like in 2 months from the time we started, this is a great achievement considering which we went through a lot of, up and down turmoil with the supply and not supply. But our relationship with the state, certainly county provides them quite a bit of staff actually to work at their website, at their clinic side. We support ours, and then also we worked with the Kinneys in the beginning because they are the one who got the green light to vaccinate seniors. We worked with them to create a waiting list for the seniors, which we started to take. It's on list, you might have seen some, probably may or may not. So 10,000 seniors actually signed up for that, and we started to take this from the waiting list, or when we see if there is any opportunity that we will just put them in our system so that they can get vaccination. So we have been able to vaccinate from all diverse group of community members. We work with the Office of People with Disabilities, OPWDD. They get assigned slots from 200 to 300. We are going to give them more. We work with the organizations who work with them. And we work with the refugee community as they are bringing, I mean, it's amazing to see that how they are requesting we want to come there. And then they will bring their translators. We provide the translation if it's not there, but they are bringing, they have them fill out the forms and they come in groups. It just becomes a very supportive environment for them, as well as it just very heartfelt, essentially, that how community comes together to support each other. If you have seen the pop-up clinics, which we have done at Syracuse Housing Authority, state gave us extra dosage of vaccine and say, we want to put a pop-up clinic. We said, yes, we are going to do that. And we had like 400 people, and we had the AME Zion. That was the first pop-up actually. And that was 100% successful. Second dose, everybody showed up. Those only people couldn't come, few of them who actually were in quarantine. So it just tells you that how these trusted partners are so important. And I continue to get the request for some other pastors. I have to make some phone calls and try to do some of the other pop-up clinics in some of the other South Side. We did in Boys and Girls Club in the East and then South Side. We have done even in Rescue Mission yesterday, and we did in Brighton Towers for the seniors. So we are doing, as we are doing, at the same time, we continue to have our clinics in the on-center on an everyday basis. We are doing first doses, second doses, and doing these pop-up clinics also. So, and as you know, eligibility has continued to increase, and now it's a 60 and over, older. And what I would hope that you as a clinicians in your practices, whichever specialty you are, I want you to encourage your patients to take whichever vaccine comes your way, take it. And I'll give you an example. We offered today Johnson & Johnson, and you might have heard there have been some news about Johnson & Johnson's that Catholic bishop has come against it because of some controversy which is not actually a fact, but that's what happens in the not so accurate news cycle. Is that people came, 4 people in the beginning of the clinic. My staff actually called, and she said that Dr. Gupta, the 4 people actually, they were very upset. They didn't want to get this vaccine. They turned away because we didn't think about that. I mean, this is something we learned, is that they didn't want to get Johnson & Johnson. They wanted either Pfizer or Moderna. For those ones, they were fine. Whether they had understanding, they did not say the reason. We said, that's fine, we respect. So I told her that, why don't you put like a sandwich board? We put the sign like you see in a restaurant, then put the sign, this is Johnson & Johnson clinic. And at the end of the clinic, I found out about 30 people or so did not come, who have registered. So that gives you a insight into people's mind, that what their fears are, what their discomforts are, and where you come into the picture when you are encouraging them. And I'll tell you stories. When I go to these pop-up sites, I am there talking to the people, and many of them will say, my doctor encouraged me to do that. I was on a fence. I just didn't want to do that. But I just felt, I asked my doctor, you play a very important role. And yes, you don't have the vaccine. I wish I had that power. I can give you and assign you some vaccine if you have applied for it. Many of you have applied for it and you're not able to get even 10 dosage, which is unfortunate. But you can be a conduit for them to encourage them to get the vaccine wherever they sign up at our website. They can, if there is any, if they are part of the neighborhood groups or church, they can, work with them. That is also another one which we work. They can go to the state side. There is a registration process there. They can go to any of the drugstores. It does not matter where they can go. They should get the vaccine, because that's how we will go towards somewhat near new normal at this point. The concern of the variant is real. We have so far in Onondaga County 1 variant from the UK one. But there are other ones floating around in New York City and all those, and people come to our community, and then it's a matter of time we will see more. So we want people to get vaccinated, and your voice is very important. So we are doing our best at this point to be very inclusive, to be learning from the community members when they are connecting with them, connecting with us, that how can we go to them if they can't come to us. So that's how. And one recommendation for me, it will be to the Medical Society. I think if you can put the Erica vaccination link some are like part of that health departments where we put in a COVID-19 that people can access there. And I would encourage all of you to put that link where you're putting COVID-19. It has state sites. It has a lot of other information there too. So it will be one shop essentially that people can go, and they have choices. They can come to our clinic, they can go to state, they can go to, to any pharmacy. That will be the way to go. And when the physicians start vaccinating, that will be another 1-2 opportunity that they can go to their physician. So I think I just, and that's what I will be happy to take any questions.
That's wonderful. You've hit on a couple of these, but can you talk more about your sense of the variants, the B117, variant that seemed to be present in California? To what extent do you think these variants are local, will be local, and how does that sort of change what we're doing and maybe impact some of the changes our community is making in terms of opening up our schools?
So right now, the state, the way it does, they take the sample from different communities. The one which we have been told is the UK variant, and there is nothing else because I checked a few days ago. There are other, they have to sample, right? So if they are floating around, they have not been picked up by the Wadsworth at this point because the sampling, the way they do for the whole state sampling. What I would say at this point is how would it change? It will change if the vaccines are not effective. At this point, what we have seen, and that's true for the Johnson & Johnson at this point, because that has been tested for South African and some other variants in UK variant, because they were tested in other countries, right? So that's shown that 100% effectiveness in preventing hospitalization and death and disease, which is fantastic. Moderna and Pfizer are looking into that also. So I'm hoping that will be the case in there. And that's why the mask, the physical distancing, all those things are still so crucial that we are not out of the woods yet. We really need to be very cognizant of that. I know CDC has provided at this point that if you are a part of the one family that you can do without the mask and physical distancing and then have get-together small ones, which is fantastic. The one thing which I would still caution about that is that you really need to make sure that your grandkids or someone, if they don't have kind of high risk behavior and going out and doing things, you still should be careful because there's still a 90-day sort of a window. They have not taken it off, that whether the immunity with the vaccine will be beyond 90 days. So right now we are sort of stuck in that dilemma right now. So the data, as soon as the CDC provides more information, we really need to keep our cautious approach to life and not put our guards down. Before I say one thing which I forgot to mention, I think it's important to you as a physician. So I did work with some large practices, including some other, I think some dialysis centers and all, to vaccinate the high risk population when the first time it came. Also work with the multiple physicians that, if you have your people, we kind of give a heads up essentially that sign up for your staff. So for the high risk population, when it was still not been that much available, we provided slots to some large practices to make appointment for your patients and give us those with a secure site, because this is all protected information. And we put them, they get their pre-filled appointments and they put patients, and then we have been able to successfully get a lot of patients vaccinated through that also. I think it's dwindling down now because it's quite a tedious work and there's more widespread availability of the vaccine. So, but it worked at that time also, that like we work with some other community. I just wanted to add that. I just forgot to mention.
Thank you. And I have more questions, but I see Dr. Burkhart, that you have your hand raised. Let me see if I can make sure. There you go.
Okay. Can you hear me?
I can.
Okay. I had just noticed one a news story talking about the use of fetal stem cells in development of the vaccines. And my understanding was that that is a bigger concern with Johnson & Johnson. So Dr. Gupta, can you speak specifically what I read in that news article was that Johnson & Johnson was actually developed using a fetal stem cell line, and that Moderna and Pfizer might have been tested in stem cell culture, but the development of the vaccine didn't involve the stem cell. Was that accurate in the news article, or is there something more you can tell us?
Right. So, I mean, it is not part in there. So you're talking about way down there. I think I'm just looking at some of those things which we have. I'm just trying to see if I can, let's see, I can just, trying to see if the Catholic Church, how they respond in the past and the parents. I'm just trying to see some of the responses.
They actually said, get the Johnson & Johnson, which was surprising to me. The article
from the Pope. Yes, I think that's what I thought, that vaccine acceptance of vaccine produced in fetal cells does not in itself constitute legitimation, even indirect. I don't know what they are talking about, the same thing. I'm just trying to see, hang on. I'm just trying to find so I can give you. Yeah, the Pope actually has said the moral obligation. So not really. I mean, I certainly can send you a formal response that might be easier for you to all to share.
Okay. Sure.
That will be, and I can send through Erica, so she can distribute. It is very crucial because, during the development, sometimes these things do happen. That is true. But I don't know how many people, if you started to look into it, it just, I cannot give you exact at this point that I don't think it happens at the end of it right now. So I certainly will be happy to give you a response which you can share with the patients word to word, that you can copy and paste. That will be a lot easier if you're doing by the email or if you are just talking to them. That will be a lot easier, I think.
Okay, thank you.
Yep.
Dr. Gupta, one of the questions that had been submitted was, do you have recommendations of how to walk folks through vaccine, or how to sort of what conversations to have with patients that are vaccine hesitant or staff that are vaccine hesitant? What seems to resonate most?
Yeah, so I think vaccine hesitancy is a very challenging topic for all of us. One thing which I always say is that never, ever try to say that, oh, I don't think any of you say that. We shouldn't roll our eyes and say, oh, this is crazy, and that. So we never try to put anybody down, because that actually pushes them further. One thing which sometimes does help is that give them all the information, and give your own personal example if you can. Share own, if you have been vaccinated, or if you have your loved one being vaccinated. And one of those reality is, what are the pros and cons, right? So of the getting vaccine. So the fact of the vaccine is that it is going to prevent the disease. It's going to prevent hospitalization. It is going to prevent death. What is fact of the disease is, if you're going to get it, nobody knows how you're going to do. Maybe you will get mild disease. Maybe you will recover. Maybe you will end up in the hospital, in the ventilator, and years of recovery, of months and months in the hospital, and a long recovery, or you will never come out and be dead. So these are the facts in a simple and polite way, just giving the facts, and people need to come to the grasp in their own time. I think if you give space to people, people do. I was talking to an African-American member of the community in one of the pop-up clinics, and I asked her, she was saying, and she came and talked to me, and we were kind of chit-chatting a little bit. She said, I was in very much fence, and I started to realize that what is exactly what I just told you, essentially. She kind of weighed herself, and then she talked to her doctor, and then she decided that it's for her time. She didn't like the other choice. And then she said, I was hesitant. I was still hesitant until here today. But I thought, I have no choice at this point. I would rather be alive, and I want to be alive. And she said, I'm still having a hard time convincing my children, who both are essential workers. So I told her, now can I give you that responsibility to convince your children, because now you are a mom and you have gotten vaccination and you become a champion of that. If you talk to 2 other people, they will have a better experience, and maybe they will listen to you. They will feel like, okay, mom didn't get much side effects. And if you get side effects, it's better than getting a disease, right? Side effects, you will get over with. I mean, I got quite a bit of side effect with the second dose actually, but you just want to get that. So it's better than getting a disease, because you are done essentially at this point, at least what we know of. So having a gentle and respectful conversation, giving them room to breathe, and continue to have the conversation. Some of my own staff actually are very hesitant, especially coming from African-American community. There is a big hesitancy. You remember the Tuskegee trial. And we had one of the member of the community who was a descendant of the Tuskegee trial, who gotten vaccination, which is, it just feels like there are people who understand the importance, and he's making his voice heard, right? So those are the things which people learn from each other. As you see the even in the news, if you see some of the surveys, there's a more people who are more interested in getting vaccine than they were before. So just be persistent. It's like anything else. If we push, it just doesn't work. And it's not required. I don't think it should be required, because then you have those who are anti-vaxxers. They become really very powerful, because we gave them suddenly a voice. There's no reason to. We should just talk about what is right and not about who's wrong. That's how I believe in, and I think it does give good results.
One of the questions we have is, what determines an active versus recovered case? Concerns particularly around patients from nursing homes that seem to be shedding for longer,
Right.
and are labeled as new COVID cases.
Right. So active cases are at this point, we had isolation for 10 days. So after that, if people have almost, have recovered from symptoms and have no fever, 24 hours, actually it used to be 3 days and 24 hours, and can have most of it is recovered. Yes, they can still shed symptoms. So I think that's why the mask and distancing still does. So they are not going to be called active cases. At one point, I think that in the nursing home cases, it was a sort of a 2 weeks, or hospitalized patient, 2 weeks. Recovered cases will be after that. We label them recovered case. The definition of recovered cases varies quite a bit, and nobody was able to give a very good definition. We even reached out to Johns Hopkins in the beginning and say, what are you putting that recovered cases means? So we all came out with our own recovered cases means is that they're off the isolation. They have no symptoms at this point, and that's how we put it, our recovered cases in the community. When you see on our website that how many people are recovered, like we have 31,000 cumulative cases, and I have to go back to my website to say 30,000 or so have recovered, sort of thing, and we have so many active cases. It means they're still in isolation. That's what it means. It means they are still going to be considered contagious. And reinfection is the one which is considered if after 90 days, if you have a positive, if you have been exposed and you have positive, that will be considered a new infection. And we have few in our community that we were surprised they were got reinfected. And anecdotally, again, it's anecdotal, is that they ironically, they were just incidental. One of them were a hospitalized patient for different reason, has recovered 4 months ago, was in a hospital. We were following that person for some other different reason. And during the discharge, that patient have to be, because we did not allow, we had to have that patient go to the nursing home. So they had to do the COVID testing. And when this person was admitted, was COVID negative. This is a recovered COVID patient and has severe complications with that, and was admitted for different reason, COVID negative in admission. For the discharge planning, COVID test within 2 weeks, was there for 2 weeks. That's what we needed, became positive. So that was kind of, whoa, what happened? So we actually went into kind of figuring it out that somebody exposed this person in the hospital. What happened? So that, again, it just like a case investigation happens and all those things. So yeah, so that was very, and there were other one also, I mean, that's what I remember uniquely, because a couple of them had no symptoms at that time, even though the first episode, so even though they get symptoms, is that antibodies are still protecting them, that they are not symptomatic, right? That sort of, it gives you a window in the vaccine. That was very interesting for us to see. So this will learn, we will learn actually as we go into the vaccination path at this point, what happens if people get vaccinated and they get COVID exposure and get infection. Do they get symptoms? Do they not get symptoms? What do we do with them? So right now, I think it's a TBD.
Dr. Gupta, how do you think, what is sort of your guidance around how long we should consider the vaccine effective? And it sounded like you were sort of, the current guidance from the CDC was around 90 days, but,
Yep.
Clearly the trials are tracking folks longer.
Yep. So we'll stick with the 90 days at this point. I think that 90 days is approaching soon. So we are all looking at CDC and say, hey, we are looking for some more statement. So it will come. This is an active conversation in the public health community and the health system community. I think this is something everybody is going to look for that. So because beyond 90 days, what happens if we find, we are talking about quarantine, the same thing, isolate quarantine, because somebody's has vaccinated. CDC has recommended at this point that you don't need to be quarantined. We adopted that in our county. State is kind of fiddling around. They have not kind of made a statement. So in that situation, we have taken the state's, the CDC's recommendation. So if you have received vaccine, 2 dosage completed, 2 weeks followed, it means you're 6 weeks down the road or 5 weeks down for the Pfizer, 6 weeks down for the Moderna. That means that if you get exposed to somebody, you're not going to be quarantined. That's what we are implementing at this point. This is a CDC policy. And we'll see. We're monitoring our cases, and they have been hovering around, and sometimes they are between 40s to 70s. They kind of vary. At this point, that has been our stable plateau point at this point.
What can you tell us about vaccine penetrance in different professions? So rural versus city populations, different ethnic groups. And I know folks are particularly interested in what is the penetrance rates sort of within healthcare workers as well as teachers.
So healthcare workers, I don't have that's something more of a state has that data, but most of the healthcare workers have been vaccinated. Listening to our conversation with our health system partners, that some of the hesitancy among healthcare workers is there also still. We were having this conversation this afternoon, actually. So there are some people still are on the fence. That goes more in the African-American community and people of color. There is again, mistrust goes there. In terms of overall in our community, if you look at our demographic sort of a distribution in our county, we are about 80% Caucasian, about 11 to 13% the African American, and then a small percentage Native American, and then some Asian, I think 4 or 5%, less than that, I think 3%. So for our community, our vaccination rate for Caucasian is about 83%. African Americans about 6.96, a little bit over 6%, between 6 to 7%. So we are working on to achieve that. The Hispanic, the Latino population is also we are not performing that. We are doing quite a bit of outreach. That's why we did some clinics on the west side, and we are involving the Latino community. Native American community is that Onondaga Nation is a part of the vaccine distribution with the state, and they have gotten from Indian Health Services. I have been in conversation with their leadership on a regular basis, and they are vaccinating their elders, especially starting with that. So there is and have advocated with the state also to provide them more vaccine, because they're sovereign nations, so they get their own supplies essentially. But if the state allows, we certainly can distribute. But I have seen that in the past that they have gotten some vaccine directly from them, and usually Indian Health Service also has provided. So there is, and also state. One thing came out very good of the task force with the regional task force run by Hub, is that there was a connectivity with the states health equity task force, in which there was a significant interest with the support to the native community, and they have been in direct dialogue with them. So advocacy works at every level, and that's, as a commissioner, that's my job, to advocate for everybody, and that's what I continue to do through our state DOH, as well as, you know, wherever we can at the lawmakers level, also at the state and federal level, and at the local level.
On that note, do you have any idea for when the eligibilities for the vaccine will change, and do you have a say in when and how this occurs?
So we don't have I think we do have quite a bit of say indirectly. So, right, we as a group of the public health professionals, health commissioners and director throughout the New York State have a voice. I am actually vice president of a New York Health County Association, which is like a mezzanine, you can say, right? So we have that. So I am incoming president for this. It will start soon. I think in May, probably we change hands. But I have been very vocal and working with the state at that executive level, working with the state executive level to advocate for a lot of those things. When you're thinking of why can't my outpatient providers can't get the vaccine, you have no idea how much I have advocated for that, to hone down to them that you cannot just leave them alone. These are people who are providing health care to these patients who are bringing COVID into their offices probably. The same thing is advocating for any other, like workplaces. So we do have that, and then also from our county leadership level. So my voice gets added by the county executive, right? So he listens to what I have to say, and then he makes it more powerful and works with the governor's office. And even at the feds, I think we talk to the senators' offices, like a Senator Schumer, who are very responsive to us. I think we want to go to those lawmakers who we think have listen to our voices, and it's just more of and also at the local state level. So I talk to actually state level with the Ways and Means, and all those different health committee chairs and all those. We continue to advocate for how we can bring more resources in our community, and that can directly will flow to your patients because they are members of the community. So we have a voice from the advocacy point of view. I do think they do listen, in terms of, for example, when we were restricted to vaccinate only essential workers, and because eligibility from the New York State actually say you can vaccinate many other people. So we, as a local health commissioner, this is my prerogative to decide that we are going to vaccinate those who are eligible. And we continue to advocate. Finally, they actually said that, yes, I think health department can do, but a lot of it is we are trying to make our voices heard at the very high leadership level, at the governor's level. By sending direct letters to them and working with their senior staff and making sure these things are happening in the policy making, because that goes to the policy making part. So I hope that answers your question. So what is changing? Yeah. So one thing is the changing. Yeah. So the 60, we were advocating for 55. So we get at least 60. I was also hoping that the hairdressers and barbers and hair salons and all those, because these are people directly in people's faces. And they unfortunately have not been. The people in the dormitories and the people in the colleges who are cleaning and are directly in contact with the students who have high risk behaviors. You know, when you're doing for the hotels and restaurants, I said, you're creating two-tier system. So it seems like they do hear it. And then next thing you feel like the next guidance comes out and they started to add those things. So it feels good at that time. Yes.
What is the process for small private offices to get the vaccine for their high-risk patient? You know that doctors are still sort of certifying through NICES, but it hasn't come directly to them. But we know there was a county process.
Right. So what we have done, it's a little bit of a tedious process. If there is an interest in this group, we can come up with more formal process in a way that we provide what we call pre-filled appointments. It's pretty basic, is that the spreadsheet mode that you fill everything which we ask for. We don't ask for the PHI. We ask that you say underlying illness. Yes, it is, or they're eligible. You certify that, but you are going to give the name, age, date of birth, race, ethnicity, their address, and you will tell them, you will call them and give them appointment, because we don't have capacity to call 400,000 people or 300,000 people to get their appointment. That's why we use the online system, mass vaccination. That's why they're successful. There are ways to do that. And because we were running against the time, we just, and also in the winter time, we can't say just walk-in clinics because people will freeze outside. We don't have that capacity. If it was we were in Florida, we'll say, okay, we can do the mass vaccination clinic. You come first time, first come, first serve basis. So that's not going to work here because people will freeze outside. So that's not happening here either. So what is the best way is that—
Do you think that will change as it gets warmer?
Yeah, physician make the appointment for their patients, fill that spreadsheet and send to the secure channel. Either they send secure email, that is one way, or we can come up with, we have actually, you can upload to our secure site on our website. We have worked with the school system and many places to upload during case investigation for contact tracing. They do, this is a very secure system with the county system. So you can upload the whole spreadsheet right there, or can send it to the secure system. So we can, but we want to have a substantial number of people, no less than 25, because it's just not worth it then. And we would, if we give you the spreadsheet based on what is available, and there is a time, the problem is we don't know what supply we are going to get. We get our allotment on Saturday night. I'll get an email with some of my other program staff is, you are going to be, you're allotted, they'll say 2 trays of Pfizer, or that is 2740 dosage of Pfizer, we'll say, right? And then it means that's going to become, that means they have ordered that for us from the Pfizer. So it will come from CDC or whichever way the system works. Or Moderna, they will say, you will get 1,000 doses of Moderna or 2,000 doses of Moderna. And then it will come on most likely Tuesday. We don't want to give any appointment slots to anyone until we have vaccine on our hand.
Yep.
We got burnt a few times, pretty darn bad. One time I took chances. I thought, oh, we are getting pretty good, steady one. And we gave the appointment. We wanted to be very efficient because everybody was saying it's too short of a time. And lo and behold, that was the snowstorm time. I have to beg and steal from every place I could think of. I didn't want to cancel the clinic. And we didn't, actually. But it was not a pleasant thing. So I said it, I'm not going to do it next time until we have vaccine on our hand and we don't open the appointment. So that's where the problem happens. That people say, you gave us the short time, this and that, and it just becomes problem. So one of those things is if we have a consistent supply, we know for this week, we will get up to Tuesday. I can give, on Wednesday, that allotment of 25 or 50 numbers to a practice that they will say that, okay, you're going to do, and then for the next Tuesday. The problem happens that people make an appointment. One of those, a reality I'm telling you, is that patients make their own appointment then and they never show up. And we have good no-show rate among physician practices also. So in the beginning, it wasn't, now started to show up because people who made an appointment, their physician took a lot of time. And the next thing they go to the Walgreens or somewhere they found out and they just walked over there and found their appointment and then got vaccination and didn't show up, didn't cancel. So that becomes a like an edged sword at this point. Do you really want to do that? But if you have people, I think one of those things you can encourage them to work with their grandparents, grandchildren or somewhere, or if you think that some of group of your patients are really having hard time, just sign them up when the registration opens. That's the easiest way, I would say, will be a good one. You get 10 patients, 10 or 15, whichever, have a couple of your staff sit down and put their registration list, and then they're signed up for that appointment. And
Dr.
then tell
Gupta,
them this is the appointment.
For the spreadsheet, is there a link that you can share in terms of where practices can upload this or have a model, or would it be helpful if the medical society tries to work with a number of smaller practices? Or
yeah, so the spreadsheet, I mean, I just want to caution you because most of it becomes very based on the experience of the other practices. First they were very excited, then they're very tired. Because it just seems like it's a lot. People, you have to make lots of phone calls to get 25 or 50 people. So we certainly can do, but we don't want to have our slots open. So we will ask at least a couple of days before that you turn that in, so that if the spots are there, we have to open that public appointments. Because last thing, we don't want to have the vaccine on our hand. We really want to put them in people's arms. There is no typical, I mean, we give the pre-filled appointments. So that is created for that practice, especially based on how they fit in. So if we have 5 practices, we are going to, some people will get appointments from 9 to 10, right? Between 9 to 10, because we vaccinate several people at the same time. And then other practice will get from 10 to 11 based on how many numbers of people we vaccinate. So everybody gets their slotted appointments in that spreadsheet, and you fill that appointment and then send the upload, or just to send a secure email back to us and then they merge the spreadsheet. So it is a tedious work. I just want to make sure that you understand that it's not easy. Those who have done it, they were kind of very excited, but then kind of got a little tired of it.
Yes, we've heard that.
Yeah, it might be a lot easier if you know that, when the appointments are opening, have a couple of people. I was talking to SU actually about this today because their eligible staff has increased. I talked to the medical director. I said they have a bunch of, custodial staff who don't speak English, who don't have health literacy, and they can't schedule. I said, so I gave her, and we work with the SU with this so much actually. So I pretty much told her the same thing. She said they're working with, they will have a couple of few staff sit down and just sign them up when that's the best way, because then there's no ifs and buts. It just makes it easier for them to, that who wants to do that, and they will give them tentative idea. And then after that, just make their appointment.
Dr. Gupta, we're hearing anecdotal reports of individual pharmacies struggling to use up their vaccine before it expires. So a Wegmans pharmacist will suddenly, put on a call through family and friends, same with Walgreens. Is there any system set up throughout the county where, individual sites that are struggling to use their vaccines in time sort of are able to, either call take advantage of on list, or, turn them back over, or,
Right. So I think so the state operates that, right? So we have a state representative who is responsible to pretty much watch out for that. And if they can always request transfer of vaccine to another one. They all know there is a hub exists. So there is if somebody needs extra vaccine, we all go through that. When I had that issue at that time in the winter storm, that's what I said, hey, I need that many vaccine, find me some, I have that many. So, and people kind of share their own wealth at that time because they want to cover. So if people have extra vaccines, they should put it out to the market. So the vaccine itself is not expired. It just because this is 7 days, that's what the state gives a sort of artificial deadline that in 7 days, use it or lose it. That's the phrase they use it. So it scares everybody because they say there'll be penalty if you don't use it, you're not going to get it again. So everybody gets scared. And I reassured them. I said, listen, you do your best. You want to put it in your arms. And if you can't get it, transfer to somebody else. And that is the way that system works. So I don't think anybody should waste the vaccine. And there are many people who are willing to take it at this point, and redistribution is a very easy thing to do in every county, actually. It's just a little paperwork, but it can be done.
Dr. Gupta, I know it's 7 o'clock, but we have a number of additional questions in the chat. Do you have time for a few more?
I can give you a few more minutes. Yes.
Wonderful. How specific do letters of vaccination, or sorry, letters need to be from physicians?
Oh, actually, we, in the beginning, when there were kind of not clarity from the governor, we said it that if you pay your patient an appointment, you can write very non-specific. This person has underlying health condition based on the criteria, they qualify. We don't need to know they have diabetes, hypertension, HIV, nothing, that confidential information, no reason to put anything down there. Right now, what we have actually adopted is that we have them people attest. So they come out, they come there, and then we have created in a consent form. If you are interested, if you try to register, you can see that consent form actually will tell you in the second page. It's a fine print, but we ask them, are you here because of, if they are not older person, if they're not essential workers, then we will ask, our staff will ask, they're not expected to tell, and they shouldn't be telling, I have this medical problem. Sometimes people want to have the laundry list. Oh, I have diabetes, I have hypertension. And say, no, okay, that's fine. If you have any underlying, we say check, and they sign the attestation. So it's a self-attestation, and we have adopted that for a few weeks actually already.
So folks can come in without a letter.
Yeah, so if that makes them feel better, if they are there, you can do that. That's fine. We most welcome that, but we are not requiring anybody to do that. So that's something should not be a extra stress on your part. But sometimes, patients do request because they want to go with all the right paperwork because they don't know somebody is going to turn them away. So I understand their concern. You can reassure them, but all has to be very simple. That these people, based on the New York State Department of Health's eligibility criteria, they're qualified to get that vaccine under, I think it's 1B, I can't remember that. Whatever that thing is, you can look into the face. I can't remember that now.
Dr. Gupta, is the health department tracing cases or tracking cases of long COVID? Are there reports of children with long COVID? Is there, sort of what data is being collected locally about how many folks are continuing to experience symptoms long after recovery?
So we don't, we as a local health department don't have the long-term follow-up on those one. We do just the case investigation, contact tracing. I think individual physicians do. New York State Department of Health might be doing it. For the children's, actually the children, they do for the multi-inflammatory syndrome, for the MIS and all. So Golisano Hospital and their team has been very involved with that. We certainly have asked them if you do have those cases, because we get every admission, we get information about that. So we do not track any of the patients long-term. So we don't have that data at all. The state probably will have those repository later on, but right now there's a lot of information, which I think you will see that data probably, I don't know whether it will be, it always takes quite some time to get data from the state. The earliest I would think, I hope in 6 months, but a year, because you're continue to collect that data. Ideally, if they can give in a quarterly basis, that will be great, because that is something. But if you're talking about long-term impact, I don't know how they're collecting that data. It probably comes from the physician's diagnosis by your codes when you get it from your electronic medical record, when you are putting the diagnosis of discharge or diagnosis of your codes. When it goes to the Healthy Connections, you all participate in that. It goes to a larger system with a nice New York State It's like it's like a mothership of Healthy Connection. It's called New York eHealth Collaborative. So I'm in both their boards, and then I can see how that data kind of gets feed up in the chain. So what you are putting it out in your medical record will go, finally, it will go into that data analysis part the way I see it, and it will eventually come. And I think some of it is to get deposited into by the state to the CDC. So those are the reports which you will get on a county level.
Excellent.
Right. So I would encourage all of you to actually go to the CDC website, and they have quite a bit of granular data with for the New York state and county level. It's pretty good, actually, since I think we have seen some of the cases and all those things. And I'm hoping the question which you're asking will be in the future at that level, because they do get final data there.
What should a practice do if there's a confirmed case of COVID with a patient or a staff member, and how does that change now with vaccination among healthcare workers?
Right. So if you're vaccinated, we do case investigation and contact tracing. So our department will work individually with your practices. And right now, I think a lot of work, which our state has been providing quite a bit of support, because it has been a whole long year. They have provided a lot of staff in terms of they are doing case investigation, working with our team. So our team will be working directly with the practice and get all the information and provide the guidance. So it's individual variation. There is no cookie cutter approach. It's just something depending on what kind of exposure, and then people were vaccinated, not vaccinated. But I think if you have in your health system, in your own practice, if you have everybody vaccinated, that creates your own herd immunity, which is good. So if the patient came and was, I hope they're all getting vaccination. So that's why I think having some kind of flyers and making sure that you remind them, and your recorded messages, if you have not received vaccination, if you're eligible, please go and get your vaccine. You can remind people that they should be taking care of themselves. I think that will provide much more secure place for your office to operate. And I think at this point, you shouldn't be that anxious as we were a year ago, right? We have a lot of tools at this point.
On that note, last question, any new sort of, looking back over the past year, any surprises around contact tracing and sort of where transmission was happening, anything you didn't expect? And are you seeing any differences in that these days? Any new developments that folks should know about in terms of what kind of counsel they should give their patients about how to stay safe and what types of activities seem to be most risky?
Right. So most of it, which we saw in last year, our case in the beginning, our case investigation revealed that household contacts were the one who were getting mostly, become positive. A lot of them didn't get tested, so we don't have the exact data, because testing was so sparse at that time. We weren't asking everybody to get tested. We were quarantining everybody, because it was supposed to be for symptomatic patients only before. And if a contact became symptomatic, then it will send it to them. With the time, we got more tools and we were able to get more testing. So we started to see that, yes, the household contacts are the one who are getting more conversion. The coworkers, depending on if they have not followed social distance guidance. I cannot tell you how strongly I feel about that based on the data I saw in our community, is that mask wearing, physical distancing is the key to success. And my heart sank a few times. Oh my God, you have 10 people in this meeting. Why did they have to do the meeting? But they were physically distant. They had all the mask on. Some people have double mask even at that time. Nobody was symptomatic. We didn't get no one converted, right? So we continue to see that, and we continue to learn. And so you don't need a whole lot. So I personally don't need all those things out from the CDC, because truly it was happening right here. And
is that affecting the thinking around children and the space?
Yeah. So children are beautiful. They put the mask on all the time. You tell them they are the most compliant. Who were the non-compliant? Are adults. young, I mean, I'm talking about young teenagers, of course, they think they're invincible. Our people in between 30s and 50s, they are just want to do experiment with everything. Even some of the older folks, Halloween parties, their backyard barbecues. It was disheartening to see professionals were doing it. You all saw the news about the residents. People were doing behaviors which were not something they should be doing it because they think it will not happen to them, right? One person, you need one wrong person in there who have been exposed to somebody, and there it goes. So we saw when people didn't follow those, it really created the outbreaks. And they were the reason. And for the children, most of the time they got it from adults. Even though when I have recommended for the schools to bring kids back more, I'm working on my larger document, which I think many of you might be interested in, decreasing distance from 6 feet to 3 feet, if you have capability to do it, is because which we saw the online, the kids who were online versus who were in person, there were no difference in their becoming cases. So it tells you at local level, that we certainly have opportunity to do certain things, and we learn from our own local data. So that is important. So mask stays, I think it's very important. Continue to enforce in your own practices, and physical distancing, it really does work, as well as the temperature checks and making sure if you have staff is symptomatic, make sure that they're not coming to work. It is important. You saw the flu. What happened to the flu? Pretty much is non-existent, right? So all these things are really tools in your toolbox to make sure you can successfully transition into your practices and can see more patients. You're using you can use telemedicine for good also, which is, I think, gives more tools to you and to your patients. I think something good out of all this, but at the same time, you do need to see your patients. You need to feel them. You need to look into their eyes and hold their hands, right? It's important. That's the beauty of being a physician, because that's so satisfying. I still, I ran into my patients here and there all the time, and I still remember those, relationships, and it just keeps you going. So
I think that's one of the first things you said to me, Dr. Gupta, is you can't always, what is it? You can't always treat the disease, but you can always treat the person, or, hear the person out.
Yep. You cannot cure everything, but you can humanize them. You can comfort them. You can be there for them, right? You can provide that space where they feel they are listened to, and you can provide them hope. I think that's what you all have been doing it. So I appreciate.
And so our hope for the rest of the year, for folks that have been vaccinated, is your guidance that they can, resume normal life. What will that look like? Should they expect a booster in the fall? Can they hug grandkids? What are you telling folks?
Yeah, I mean, grandkids, the CDC has come out actually that if you have your most family vaccinated and you have your grandkids, yes, it's time to visit if you can. That's good. Travel, they're in fence right now. I think that is still a little controversial at this point from CDC. I think I can understand it's a new administration, so they will take a little cautious approach and come around, including the school guidance. I'm pretty sure they will come around in a short few weeks, because if you want to open the school, yes, I think just be cautious, and in your own friend circles, if you really know your circle, and it's like you're creating your own pod essentially, that you can enjoy that, and vaccine gives you that protection a little bit more. I think that's what I personally am trying to do, but it doesn't mean that you just go out and sitting out in the bar. I think we'll see what happens. I think they are going to be opening. Just be cautious, be thoughtful, because we can control our lives. We cannot control the virus. We can control our lives. I think that is very important. Important thing for us to remember.
We are very grateful to have this opportunity with you. And Sandy was saying it was almost a year to the day that you last spoke to everyone, and you're looking well, and you must have a sort of a sense of, or a store of energy that the rest of us don't have to keep going after all this
it
time.
Keeps me, hope keeps you going, because you just you go to bed at the end of the day. I do believe that, you know, all of, I mean, you are my all colleagues, and we always think that, did I do everything which best I could have done? And if the answer is yes, then you can sound sleep. You take care of yourself. I do my exercise. I do my yoga, whatever best I can. And I do self-care. It is important. And I hope you all are doing it, because you can't take care of anybody, including your own family, if you're not spending time for yourself. So it is very important to spend time for yourself, and so that you can stay strong. You know, there's no vacation in my life right now, but that's okay. As long as I can get some sleep, which I am getting it, and it gives me energy, because there's a hope. There is a lot of things which we can do, and we can put the virus behind. And I appreciate your partnership. So thank you, and
Thank
stay
you
safe.
so much. Thank you.
Take care. Bye-bye.
Bye-bye, everyone. Have a wonderful evening. Thank you so much for joining us.
Thanks, everybody. Good night.
Night.